Good morning. Good morning. Okay, I'm waiting. He doesn't want me to talk yet. Yeah, he's got me. Okay, perfect. Thank you. Good morning, everyone. I don't think I'm on yet, but I'm sure Andrew will work on it. There we go. Perfect. So for the third time, good morning. Welcome to day 2 of our meeting. I hope everybody enjoyed the first day. Looking forward to another really interesting day. Slightly different bend perhaps today, but I think it'll be really good. As a quick reminder of a few things before we get started, don't forget to keep your ID badges on. And don't forget when you're down to visit our sponsors, and a big thank you to them again. As a reminder, our platinum sponsors from Baxter and Fresenius, silver sponsors from Amgen, Otsuka, Nurse Next Door, Medtronic, and Janssen. And again, without them, the meeting doesn't happen. So do take your time to say hi. We should have a very good morning today. I don't think there's any other housekeeping that I'll tell you about right now. I'll remind you more at the end of the day. But to keep us going and on schedule, I'm going to have Dr. Dasgupta come up and just introduce the next couple speakers.
Thank you, Dr. Jamal. The speaker that we are presenting first today doesn't need any introduction. He's Dr. John Crabtree. He's in the faculty of the UCLA Harbor Medical Institute and taken the time and accept our request to come and talk to us. He is renowned worldwide for his contribution in PD access creation. You should know that he is a surgeon, but he dedicated his career in teaching new nephrologists and surgeons in a very dedicated way, because he's in the faculty and the chair of the Pd University in North America, and he's also well recognized and teaching in Europe as well. So we have a very good, knowledgeable speaker on the subject of peritoneal dialysis access. So without further ado, I would like to invite John to speak. John.
Thank you, Dr. Dasgupta, for that introduction. It's certainly great to have the opportunity to participate in this symposium, and I do want to thank the Planning Committee for extending an invitation to me to speak to you about effective use of laparoscopy to create peritoneal dialysis access. Now, if we take a look at the different ways that we can create peritoneal dialysis access, they can be conveniently categorized as placement by open surgical dissection or some form of percutaneous puncture, whether this be by Seldinger technique, needle guide wire, guided by either fluoroscopy and or ultrasound, or the Witek approach, which is a proprietary laparoscopic assisted approach, or by surgical laparoscopy. Now, when we take a look at papers describing different ways that catheters are implanted, we quite often run into a statement from the author that no single Pd catheter implantation approach has been shown to produce superior results. And this is often offered as a justification for the particular procedure that's being described in that paper. But with regards to laparoscopy, there actually is some evidence to indicate that one procedure may not be any more advantageous than another. If we look at randomized controlled trials comparing laparoscopic Pd catheter insertion to other methods, we find that the results are mixed. These are the 4 randomized controlled trials that have been studied to date. The first 3 on that list, they compared laparoscopy to open surgical dissection, and the last one by Voss compared percutaneous image-guided approach. And you can see that The results here, except for the one study, show no significant difference in outcomes with regards to flow function between laparoscopic placement and other catheter placement methods. Now, one of the criticisms of these randomized controlled trials is that the subject numbers in these studies are small, and so it was felt that these studies are underpowered. But if we combine these together in a meta-analysis with flow function as our primary interest, we still see that there's no significant difference between laparoscopic placement and other catheter placement methods. And so what we have here, excuse me, I'm getting ahead of myself here. Let me get back there. Okay. And so if we take a look at this, we see that this diamond representing the summary effect of these other studies, that the 95% confidence interval crosses the risk ratio line of 1, indicating that there's no significant difference between laparoscopy and other catheter placement methods. If you're curious about the Wright study in 1999, it's not estimatable, and this is because there were no flow function events in either one of the groups, and with a risk ratio of 0 divided by 0 is 0, so they're not really able to estimate an effect size. Now, I refer to this as basic laparoscopy. This is, I want to define this for you, that basic laparoscopy is using laparoscope only to verify the position of the catheter tip. No other interventions were performed. Now, there's actually been 3 meta-analyses comparing laparoscopic to open Pd catheter insertion by Shea, Hagen, and Chow, and they included randomized controlled studies as well as retrospective cohort studies. And again, you can see that there is variation in the response of these, in the findings of these meta-analyses. Part of looking closely at these meta-analyses, they were all unfortunately flawed in that they did have errors in event counts, but more importantly, all of the laparoscopic papers were considered together, not acknowledging that there was a mixture of intensity of interventions in the laparoscopic group. And what I mean by that is that a lot of the papers were just the basic laparoscopy, using the laparoscope only to witness the catheter tip position, as opposed to other studies in which the laparoscope was accompanied with adjunctive procedures to try to improve catheter outcomes. And so they missed an opportunity with these meta-analyses to define an important concept that I want to share with you today. Now, this is a randomized controlled cohort studies comparing, again, basic laparoscopy to other catheter placement methods. The majority of these are comparing it to open surgical dissection. The Gahar study here was blind percutaneous, and the Voss and Mayer was percutaneous guided by fluoroscopy. And again, we can appreciate that the summary effect of all of these studies, indicated by this diamond for the summary effect, shows that there was no significant difference between basic laparoscopy and other catheter placement methods. Now, if we take a look at cohort studies comparing advanced laparoscopic Pd catheter insertion to open surgical dissection, we see an entirely different result. And what I mean by advanced laparoscopic placement is that there were adjunctive procedures performed. I've initialed these in parentheses next to each of the author by year. And the key for this is that R equals rectus sheath tunneling of the catheter, O is omentopexy, A, adhesiolysis, L, loop suture anchor, which they looped a suture through the abdominal wall to keep the catheter oriented toward the pelvis, and S was actually suturing the catheter tip to the pelvis. Now, these studies used one or more of these particular interventions, but you can see that the summary effect was that it produced a significantly better outcome with regards to flow dysfunction than the open catheter dissection method. And these different studies are available to you upon request. Now let's go back to the catheter implantation approaches. What I'd like to share with you is what's currently going on in the United States, and that is that shown here is the proportion by which each of these catheter placement methods are currently being used. Open surgical dissection was previously the gold standard and was the most common way that catheters were placed, and it still is in many places around the world, but it has greatly diminished, falling down to 18.5%. And then our cell dinger technique with and without fluoroscopy, but mostly with image guidance, has really jumped up to almost 29%. And this is because of the interest in urgent start, as well as involvement of interventional radiologists in placing catheters. The YTEC procedure has almost completely fallen into disfavor, and surgical laparoscopy has had a dramatic increase of more than half of the catheters currently being placed by this method. If we look at what's happened with laparoscopy over the last 7 years, for which data has been made available, we see that it has continuously increased to more than half of the catheters being placed by this method. And I think this is because that surgeons are finally coming around to realize that laparoscopy enables many inarguable advantages over every other catheter placement technique through the ability to perform adjunctive procedures, such as rectus sheath tunneling, which keeps the catheter oriented toward the pelvis to prevent catheter tip migration. It also has eliminated pericatheter hernias and greatly reduces the risk of pericatheter leaks. And then attacking up the omentum, omentopexy, to prevent catheter obstruction, taking down surgical adhesions, not only to enable placement of the catheter, but to eliminate any recognized compartmentalization within the peritoneal cavity that can interfere with dialysate drainage. And then taking care of the epiploic appendices when they're found at the time of the implantation procedure to be such that they interfere with catheter flow dysfunction, and then tacking up even the rectosigmoid colon to open up the pelvic inlet when there's discovered to have problems during the catheter implantation procedure with catheter flow function. And then, of course, laparoscopy allows us an opportunity for diagnosis and simultaneous treatment of previously unsuspected abdominal wall hernias. Now, I want to briefly describe each one of these in more detail. It's not that I'm trying to make surgeons out of you, but instead informed resources to your surgeon so that you can better communicate your expectations from them. We'll begin with laparoscopic guided rectus sheath tunneling. This is a technique that can be performed in several ways. What I'm going to show you here, I think, is the safest and simplest way. And it involves the use of a specialized port system that's actually available globally. It consists of an expandable plastic sleeve that fits over this varus needle. That needle with the overlying sleeve is pushed through the abdominal wall. The needle's removed, leaving the sleeve behind to serve as a conduit for insertion of this laparoscopic port. This schematic shows how that is performed. In this schematic, the feet are to the right, the head is toward the left. This is the skin. This is the subcutaneous tissues. This is the anterior rectus sheath, the rectus muscle, and the posterior rectus sheath and peritoneum. And so through the insertion incision, the needle with the overlying plastic sleeve is inserted through, pushed through the anterior rectus sheath, the rectus muscle, and it can be seen as it tense down the posterior rectus sheath laparoscopically. It's then turned and angled toward the pelvis and slid down the surface of the posterior rectus sheath for a distance of 6 centimeters before pushing it through into the peritoneal cavity. And then the needle's removed, leaving the sleeve behind to serve as a conduit for insertion of the laparoscopic port. Once that's in place, the catheter's inserted, the port's withdrawn, leaving the catheter in this long rectus sheath tunnel oriented toward the pelvis. Now, this little video clip shows that process. And the feet are to the right, head is toward the left. We'll see here some local anesthetic being infiltrated through the abdominal wall for postoperative pain management. Once that's been accomplished, the needle with the overlying sleeve is inserted through the skin incision, and we'll see here in a moment where it's tinting down the posterior rectus sheath and peritoneum. Instead of coming through, it's turned toward the pelvis and slid down the surface of the posterior rectus sheath until we get to the area of the anesthetic wheel where it's pushed through into the peritoneal cavity. And once in place, the needle is removed, leaving that plastic sleeve behind to serve as the conduit for insertion of the laparoscopic port. And here we'll see the white dilator of the laparoscopic port coming through the sleeve, and once that's in place, the dilator is removed to complete the port placement. Now that was a long description, but you saw it in the actual time that it takes to perform that maneuver. This is the external view of what you just saw. We were watching it through a 5mm laparoscope on the opposite side of the abdomen, and here's our port now in the rectus sheath tunnel. Our Pd catheter now is straightened over a stylet and advanced through the port under laparoscopic control. And the stylet's partially withdrawn to allow that coiled tip to form up, and it's pushed down into the pelvis, and then we'll continue to advance the catheter until we get a little bit of a glimpse of the deep cuff right about here, just to make sure that it's passed into the rectus sheath. And then the port is withdrawn, leaving the catheter to emerge from the insertion incision, and then the catheter is pulled back until that deep cuff is just below the anterior rectus sheath, and we'll add a purse string suture around the fascia here to further minimize the risk of pericatheter leak. And then the catheter, of course, is tunneled to its exit site to complete the catheter placement. Now, we all know that the omentum is a very common cause of catheter obstruction. It wraps around the catheter, initially producing outflow obstruction, but will progress to inflow and outflow obstruction. The omentum is this fat-laden sheet of peritoneum that hangs down from the greater curvature of the stomach and the transverse colon, covering the colon and small intestine. Normally, it doesn't go much lower than about the level of the umbilicus, but in some patients, it can extend all the way down into the deep pelvis. And here we are looking down into the deep pelvis. This whitish rim that you see here is the upper border of the urinary bladder. The pubic symphysis bone is at about this level, and these blood vessels in this fatty-looking tissue is the filmy omentum overlying the small intestine, extending down into the deep pelvis. And so if we implant our peritoneal dialysis catheter here, you can see that it is a perfect setup for an omental wrap. And so when we recognize this at the time of the catheter insertion procedure, we'll insert an extra port so that we can use a grasping instrument to pick up this omental apron and drag it up into the upper abdomen away from the catheter and suture it to the abdominal wall in the upper portion of the abdominal cavity so that the omentum stays away from the pelvis and the catheter tip. Now, this little video clip shows that process. Again, the feet are to the right, the head is toward the left. This is the costal margin right here. And the needle carrying a suture, and this is a blunt needle, going through multiple folds of the redundant omentum. And once that's accomplished, the suture is retrieved from the needle. The needle is withdrawn from the abdominal wall, inserted through the same skin incision, but slightly different abdominal wall location, grabs the other end of the suture, and this large U-stitch is pulled up to the abdominal wall and tied to complete the omentopexy. It takes less than 10 minutes to do this additional procedure. Now, more than half of our patients have had some form of previous intraperitoneal surgery, so it's not unusual at all for us to run into problems with adhesions. Adhesions create a problem when it's in the way of optimal catheter placement, or you recognize that there's compartmentalization within the peritoneal cavity that can interfere with dialysate drainage. So when we recognize this during the catheter placement procedure, we'll insert extra laparoscopic ports, and then using any of a variety of instruments, we'll take down these adhesions. There's no need to take down every adhesion, but just those that allow you to optimally place the catheter and to eliminate the compartmentalization. In this particular video, we're using an ultrasonic shears, which is a blunt-like scissor device that uses ultrasonic energy to coagulate and divide the tissues, and you can see that it does it in a bloodless fashion. Now, the epiploic appendices are these little fat-filled nubbings tabs that are hanging off the serosal surface of the colon, and they are particularly predominant in the rectosigmoid region in the vicinity of where the catheter tip comes to rest. Now, when they're short and stubby like this, they cause absolutely no problems, but sometimes they can be long finger-like projections like you see here, and these can siphon up to the catheter tip and cause obstruction just like the omentum. This is one of the important reasons for us to do an adequate flow test, irrigation test of the catheter upon completion of the catheter insertion with an adequate volume to allow things like this to appear. Because a lot of times just looking in there, you may miss these redundant epiploic appendices. So we'll use a 1 liter of saline in and out flush. And if we have problems with a sluggish drainage or incomplete drainage, then just simply sticking the laparoscope back in and finding out what causes the problem. And on occasion, this is the culprit. We would rather take care of this at the time of the implantation procedure than to have to come back at a later date to remedy a problem with the epiploic appendices having obstructed the catheter tip. So this just shows the resection of the epiploic appendix, again using the ultrasonic shears. This is the sigmoid colon here, and then carefully the epiploic appendix is resected and then removed through one of the laparoscopic ports. Now, on occasion, when we do our irrigation test, we'll have good inflow, but then we'll have sluggish or incomplete outflow. And when we look back in, we see that appreciate that we have this big, fatty, redundant sigmoid colon on occasion that essentially plugs the pelvic inlet, burying the catheter deep in the pelvis and accounts for the slow or incomplete drainage. And when we notice this, what we'll simply do is just take this colon and pull it over to the sidewall and stitch it in that location so that it opens up the pelvic inlet and returns a catheter flow function. Now, I mentioned to you that laparoscopy allows us an opportunity to discover and treat hernias at the time of the procedure. We always examine our patients preoperatively looking for hernias, and we'll repair those at the time of the catheter insertion procedure, but we do advise our patients that if they're difficult to examine or the hernia is small, we may possibly miss some of them, and so we do consent them in advance for repair of any hernias that are discovered during the course of the catheter implantation procedure. And so these are just some examples of an indirect hernia in the male, indirect hernia in the female, a small umbilical hernia defect, and a less commonly encountered Spigelian hernia, which occurs at the lateral border of the rectus muscle. Now, at times we have challenging patients, those who may have surgical adhesions from previous operations, especially those patients who have intestinal stomas, but they want to do peritoneal dialysis. And so, the question comes up, can they do PD? And what method would you use to insert the catheter? Well, certainly, laparoscopy enables access in patients that you might not ordinarily consider for peritoneal dialysis. In addition, you think about what's the best way to provide peritoneal dialysis access in the obese or morbidly obese patients. And certainly, laparoscopy not only enables access, but it minimizes the magnitude of surgical stress and trauma that the patient would experience if you were to approach them with a conventional open dissection placement of a catheter in this patient. There are no randomized controlled trials comparing advanced laparoscopy with these adjunctive procedures to basic laparoscopy where the laparoscope was used only to witness the position of the catheter tip. But we do have 3 retrospective cohort studies that we can look at. The first one is from our institution in Southern California. Adoluri is from Cleveland Clinic, and Kreselek is from the University of Chicago. And we can appreciate that in these studies, all of them showed a significant favoring of advanced laparoscopy over basic laparoscopy, and the summary effect, of course, with this 95% confidence interval, shows statistically significant advantages of using advanced laparoscopy over just witnessing the catheter tip with the laparoscope. Catheter survival, if we have improved catheter flow dysfunction, then certainly we can expect that catheter survival free of mechanical flow obstruction will also be improved. This again is from our institution comparing advanced laparoscopic catheter survival after 2 years to basic laparoscopy and to open surgical dissection. This is the Kresilek study from the University of Chicago, again, demonstrating that advanced laparoscopic placement produces better results than either basic laparoscopy or open surgical dissection. And then, of course, just combining these two studies in a meta-analysis, again, demonstrating that the summary effect favors advanced laparoscopy over basic. Now, one of the things that is often said about laparoscopy is that, it's expensive. We can do these procedures in a less expensive fashion with other methods. And that's true. Laparoscopy is more expensive than open surgical dissection or percutaneous image-guided placement. And it's shown here a procedure cost of radiologic and open catheter placement as a fraction of laparoscopic insertion costs. And so that open surgical dissection is about 80% of the laparoscopic cost, and radiologic is about half expensive as the laparoscopic placement. In US dollars, the average laparoscopic procedure is just under $2,000. If I did my Canadian conversion correctly, average cost is around $2,600. And so if we look at this, there's anywhere from a $500 to a $1,300 difference in the cost of a conventional open and radiologic placement compared to laparoscopy. But I think we should keep this in perspective. We're looking at a procedure that can produce better outcomes and therefore better catheter survival, keeping the patient on therapy longer, not having to deal with complications that are expensive to fix, or the cost of transferring the patient to hemodialysis. If we take a look at the cost per patient per year by dialysis modality here in Canada, and this is information from the University of Alberta by Clarenbach et al., and it shows the cost of hemodialysis in-center, satellite, and then, of course, home therapy, and then the cost here of PD patients. And so what we have here, of course, is a difference in annual cost per patient per year between HD and PD of around anywhere from $15,000 to $51,000 Canadian dollars. And so I think if we're concerned about anywhere from a $500 to a $1,300 difference in the cost of the modality to place the catheter, that figure is trivial compared to what your potential savings might be. Now, the other concern that's often expressed about laparoscopy or any procedure that requires operating room access is that there may be a delay in the PD access procedure. And there's no question that in many facilities, the line to the operating room is longer than the line to the radiologic suite or the procedure room. There are surgical barriers for timely intervention. Unfortunately, many surgeons, because of lack of training, are less than enthusiastic about performing PD access procedures. To them, PD patients can be complicated and time-consuming, and they don't really know what to do when a complication arises. There's also the problem of a lack of understanding of the importance of appropriate prioritization of the PD access cases. They get added on to the end of the surgical schedule at the end of the day, and the patients have been NPO all day, nutritional intake, and then if they're running overtime, the patient gets canceled and put on for another day, and so that becomes a major problem, a major hurdle in getting timely access for the patient. And then surgeons become worn down with a constant struggle over trying to acquire adequate operating room time. There's a negotiation that ongoing with medical administrators or hospital administrators to get adequate operative time. And then, of course, their incentive and motivation for PD access procedures is reflected by the poor remuneration. You know, after all, there is a business aspect to medicine. The surgeon does have to be able to put food on his table and keep his kids in shoes. Now, I've got a solution for the first two bulleted points, but unless one addresses these, then anything we do here may be for naught. What we can do for your surgeon is to provide surgical education. You know, many of the residency training programs really have minimal or even sometimes no experience to offer the residents in PD access. And so, you know, really to them, putting in a catheter is just sticking a tube in a hole. They don't really understand the other little things that have to be, the myriad of details that have to be performed in order to get an adequate access. So the ISPD has implemented a global education effort for surgeons. We've had it here in the United States for a number of years. We've just this last year have implemented the same program in Europe, and hopefully in the near future we will be in Asia with the ISPD, Peritoneal Dialysis University for Surgeon. It's comprised of didactic instruction for the surgeon and also a surgical laboratory where the surgeons have hands-on experience in placing catheters, learning how to do rectus sheath tunneling, to be able to do omentopexy. We teach them how to do pre-sternal catheters, how the proper way to externalize catheters, embed catheters, preoperative mapping to determine the most appropriate catheter type and exit site location. And so it's a process of allowing the surgeons to develop competence and confidence in placing catheters. And we've surveyed these individuals after they've taken these courses. When they do go home, we do influence their surgical practice. They are doing these things, so this is an effective program. We just recently had one here in Vancouver last November. Our next program is at the end of this month, April 28th in Tampa, Florida. Certainly one can look at the internet address here to look at locations and dates of upcoming programs. Now, in summary, the advantages of laparoscopy for PD access is that it does enable adjunctive procedures that produce better catheter survival and free of catheter flow dysfunction complications. As we pointed out, it does enable a larger candidate pool of patients for peritoneal dialysis, especially those who have had prior abdominal surgery, and especially those with multiply operated abdomen or those who have had a previous PD catheter that was removed for peritonitis, because we can effectively deal with adhesions. And also it's enables operating on patients who are obese or morbidly obese to provide a stable and durable peritoneal access. Importantly, it also allows co-interventions, and this is in addition to the adjunctive procedures that we described. It allows us to take care of things like simultaneous cholecystectomy, and as we pointed out earlier, hernia repair. In the United States, if a patient has gallstones or gallbladder polyps, a lot of times they cannot be listed on the transplant list until they are until the gallbladder has been removed. And so when we do have a patient come in that we perceive to be a potential transplant candidate, we will get a screening ultrasound looking for stones and polyps, and if they have it, we'll go ahead and do the cholecystectomy at the time of the catheter implantation procedure. And so these are the advantages of being able to use a laparoscopic approach to secure peritoneal dialysis access. And again, thank you for the opportunity to be here to present this to you. Are you going to enable questions?
Okay. We are open to ask questions to Dr. John Crabtree.
At a previous talk that I was at, I think one of the physicians was advocating for catheter placement lateral to the midline. Now, is that something that you've adopted, or are you predominantly going midline to the linea alba?
Okay, and so when you saw the rectus sheath tunneling, actually the only way you can do that is to do a paramedian approach. And although one can argue about the data, the concern is that through the midline it's difficult to get adequate catheter immobilization and fixation. And so depending on how much you bend that catheter to produce an exit site location, you may induce memory resiliency forces that can increase the risk for catheter tip migration or superficial cuff extrusion. In addition, when you're in the midline, if you need to come back at a later date to do a simultaneous catheter replacement, if you're in the midline, you've kind of made it difficult to go to an opposite side to place a new catheter and have an adequate margin.
Mm-hmm. And sort of in terms of vascular complications of that sort of just slight lateral to midline approach in terms.
And I didn't show you that, but with the laparoscope, you can actually see the course of the inferior epigastric artery in the rectus sheath. It's like, it comes in laterally to the rectus sheath and stays on the surface of the posterior rectus sheath for a distance before it it gets up into the muscle tissues. And so you can actually see the course of the inferior epigastric and avoid it during insertion of the port.
Yeah, so I guess I have one follow-up question to that, and then I'll let other people ask, but I actually have another question. Now, in terms of when that's great when you actually have access to a laparoscopic procedure and when a surgeon is doing it. Do you think that that's generally a safe procedure to do if it's being done bedside, either with a radiologist or an interventional nephrologist?
And so you can use an ultrasound to map out the course of the inferior epigastric so that if you're going to do a percutaneous approach, that you can identify the location of the inferior epigastric vessels and stay away from them with the insertion of your needle and guide wire.
Thanks.
Dr. Singh.
Do you think that the 18.5% of procedures that are done open surgical are done because of inadequate laparoscopy skills or cost, or is it because it takes less time, or what's the reason for that? Because I'm just wondering how that compares to like elective cholecystectomies in the US. Are they that proportion open right away, or laparoscopy, or?
Initially with laparoscopic cholecystectomy, there was the people who were still hanging on to open cholecystectomy. There's always that bunch. But eventually, if you were to attempt to offer your patients open cholecystectomy now in United States, you'd be out of business, right? Okay, and I think we see the same thing eventually happening with Pd catheter implantation. It's just because the volume is slower, is lower than cholecystectomy, and the surgeons still have inadequate instruction or educational background, that we're just seeing that transition happening more slowly. The other thing too is that the reimbursement for open dissection has begun to decline as well, and I think it's because CMS, our Medicare, is actually seeing that the outcomes are better with the laparoscopic approach than open surgical dissection, and even the reimbursement for radiologic percutaneous is also diminished. And so I think that we see some incentive being applied to utilize a procedure that produces better results, and I think that people are following the dollar.
Dr. Crabtree, have you done this in children, and how low would you go in terms of age?
Okay, and so my experience is with adult patients, but there are studies out there in which rectus sheath tunneling has been done with a pediatric age group. And they're case series reports, not a cohort comparison. But yes, it has been done with rectus sheath tunneling, and also we're encouraging omentopexy because we're discovering that the omentum may have some type of immune protection especially for pediatric age, with white spots that are in the omentum. So instead of resecting omentum, which is commonly done in the pediatric age group, we are encouraging them to do omentopexy instead.
That was a great
Jeff,
talk.
you're not allowed to ask questions.
It was excellent. And my one question is about the controversy of straight tip versus coiled tip catheter ends. And we're going through this at my center right now where there's some discussion about that. The evidence is a little bit confusing as to which catheter design type yields more optimal outcomes. I was hoping to get your opinion on the issue.
Yes, and so actually if you take a look at the data, and there are some meta-analyses that again are somewhat flawed if you look at them closely, but if you go back and kind of take a look at it again, there is absolutely no difference in flow function between a straight tip catheter and a coiled tip catheter. There's absolutely no difference in outflow discomfort or inflow discomfort between a straight tip and a coiled tip catheter. So I think that the reason that we in North America are using coiled tip catheters predominantly has been an excellent marketing occurrence. I think with the interventional radiologists becoming more involved, we're seeing more straight tip catheters being inserted. Yes.
Thank you for that. So, acknowledging all the limitations we have with resources, particularly in socialized environments, what would you suggest might be an approach to dealing with the diverse strata of patient population? So this would be the gold standard, and we'd love to have our patients go there the first time, get their catheter, and and that you predictably are going to probably get something that's going to be working, rather than having your patient go in, having an interventional nephrologist put it in, and then realize that tip's migrated, there's omentum to be dealing with, and then send them in a second time to have things done laparoscopically. And in our environment, we have that sort of strata approach where we blindly send people without prior surgery to have an interventional nephrologist do it. We have conscious sedation for people who've had prior surgery and have it done by a surgeon, and then, of course, the more complicated cases get laparoscopy. A few years ago, one of the surgeons came up to me, one of the leads in our program, said, can you advocate for us to get more operating room time to be able to do more laparoscopic procedures? Because he really believes, and we really all believe in your suggestions. Unfortunately, when you go to get funding for this, the chances of that are very slim, considering how the pressures overall in the operating room are in any program. So what might you suggest might be an approach where you're really doing the best service for the patient, and at the same time capturing the highest need patients to be able to provide this kind of service?
Mm-hmm. I can certainly share your comment about appealing to medical directors and hospital directors and whoever else controls your operating room time. I also have that problem, amazing enough, and when I've actually gone to my medical director and asked for more operating room time to take care of some urgent patients, and they asked me, what makes you so special? And so, you have to say, it's not me that's special, it's the patient that is special that needs the surgery. I think what we try to do with Peritoneal Dialysis University for Surgeons and now for Peritoneal Dialysis University for Interventionalists is that we are stressing a collaborative approach. We recognize that there are problems with operating room access for laparoscopy, and we recognize that their patients benefit from being able to start dialysis, PD acutely or urgently. And so our stress has been to teach the best demonstrated practices in catheter placement. So there are obviously some things that the radiologist or interventional nephrologist can't do. They can't do omentopexy. We do have a way that they can do somewhat rectus sheath tunneling under the guidance of an ultrasound, but there are other techniques, taking down adhesions and other things that one cannot do. But if one has placed the catheter interventionally, utilizing best demonstrated practices, and they have a problem with catheter tip migration, or they have a problem with omental entrapment, then it's very simple for the surgeon to go back and fix those particular issues without removing the catheter and without interrupting peritoneal dialysis. Now, if the catheter has not been placed utilizing best demonstrated practices, and I've encountered this, then you end up having to replace the catheter. So I think the collaborative approach means that we're all on the same page in planing the catheter to the optimal ability of that particular method, utilizing the best demonstrated practices.
John, just one follow-up question limited to following up from Jeff's question. So the straight versus coiled, I get. What do you like to use for your exit site? Do you use a straight catheter or do you use a swan neck? And does it really matter to you?
It doesn't matter to me. What matters to me is what fits the patient. So we go through a process of preoperative mapping to determine which catheter type is best suited for the patient, which will take into consideration lower abdominal skin folds, or skin creases, or just general obesity of the patient, belt line locations, occupation, things of that nature. And so that will determine whether we're using a straight intercuff catheter or a catheter that has a preformed swan neck bend in the intercuff segment. We find that that many times patients have lower abdominal skin folds or their belt lines are such that the swan neck catheter is not suitable. Okay, in fact, we find for one-piece abdominal catheters that we more often, with the mapping process, end up using a catheter with a straight intercuff segment that we bent to produce a laterally directed exit site, not a downward one, okay? And then, of course, if you're mapping and you get to patients who are getting to a BMI of 30 or more, then you usually end up having to use a two-piece catheter to produce an upper abdominal exit site or actually a pre-sternal site. So it's the catheter selection is determined by the mapping process.
I just wanted to ask, for the sake of the audience, and ask Jeff if in Toronto they're still doing a lot of the repositioning through interventional radiology, because this for us has been an issue. So we would occasionally have straight catheters being repositioned with interventionalists, very rarely, but when it did happen, sometimes we had success. Now we can't do that when we're using coiled.
Stay tuned for my presentation.
Right on. Thank you.
Can I just say one thing about the straight curled? So when I started doing tubes, they were all straight, and then we moved to the curled, and about 2 years ago, I moved back to straight. So I think, Jeff, you had sent an email out saying, is anybody doing straight catheters? It's all straight right now.
And it's so funny that John said what he said, because it's my radiologists who are pushing the straight tip for some reason over the surgeon. The surgeon's quite happy with the coiled tip.
Yeah, and the reason radiologists like it, because it's easier for them to thread it through the peel-away sheaths.
Renal, if I may, just one further observation, and it follows up on a beads question, and really for the audience. We've had a couple of cases in skinny patients where we've used the swan neck, where it's more rigid, as you appreciate, than the straight intercuff segment, and we actually had that move forward and erode the skin over the swan neck segment, and we've seen that in a couple of skinny patients where there's obviously less subcutaneous tissue. So my preference is certainly in those patients, and perhaps generally to go to the straighter intercuff segment.
Okay, I will take the chairman's prerogative to ask the last question.
I thought I was off the hook.
John, you presented with an emphasis that you divided the insertion of peritoneal catheters has to be done by laparoscopy, and then you divided again into basic and advanced. And your emphasis as a general surgeon is advanced laparoscopy would be ideal. The data that you compared by meta-analysis and other things, it shows up to 2 years advantage. But in general, whatever method we use, our patient's catheter survival and patient survival goes up to 3 years. Do you have any data for 3 years? That's question one. And you have introduced another important thing that's coming very rapidly, that radiologists are trying to take over the procedures from the biopsy up to the catheter insertion. I don't feel that is very safe because we had some accidents in our hospitals, and I'm not in favor of that. So you introduced to the audience the same concept, and it's coming like a wave because it doesn't take an operating room, and the radiologist can do it in a different manner with their force of residence and other things. Please comment on that.
Okay. Your first question was?
Advanced
versus basics. Okay. And I forgot what the
question was why you are in favor of advanced laparoscopy.
You know, because
and not basic
right.
laparoscopy.
And so So really, it's a waste of resources if you're just going to use the laparoscope to witness the position of the catheter tip, okay? Because as we pointed out, there's really no difference between that and blind surgical dissection or interventional radiology dissection or open surgical dissection. So if you're going to bring the laparoscope to the procedure operating room, then use it for something. And that's what I've tried to point out here.
My point was that we are training our residents and you are having the PD University, so we are expecting they will be practicing outside the big institutes and the big cities. And population migration is happening, and so we have to provide PD to the greater population. So the basic laparoscopy training would be easier, but to have a advanced training, they have to have a surgical background in their medical career.
I think there's really not a lot of rocket science in the adjunctive procedures that we talked about. A lot of it's just convincing the surgeons, giving them the confidence that it's something that they can do. Generally, they go like, "Oh, I can do that," but. If they can do laparoscopic cholecystectomy or appendectomy, they can do any of the adjunctive procedures that we talked about. It's just a matter of giving them the confidence to do it, allow them to go through the process. Okay. I think as far as interventional radiology, again, it's, radiologists don't really understand they're the newcomers in providing PD access. And they're not really familiar with all the nuances that are involved, all the little nitpicking details that are involved in creating a durable and long-lasting PD access. And I think, again, that's something that can be corrected by education.
Thank you, John. Thank you very much for coming and educating us. Our next speaker is very well known at a very young age, Dr. Jeff Perl from the University of Toronto. I won't take too much time to introduce him, only to say that he has taken time to complete his nephrology training and then went to the Harvard for epidemiology, and he has been endowed with very generous grants to do some research work, which is still not published. I was hoping he will give some hints to us, but he is also a brilliant physician dedicated to peritoneal dialysis, and the title explains his dedication. Jeff?
Thank you for the introduction. It will get done. And so, I'm a little bit anxious to give this talk, and it's really wonderful to be back in BC amongst friends and colleagues. And I've been to Western Canada PD Days, and I'm just in awe that such an event happens here, and unfortunately not in more other places in the country. But I'm a little bit anxious because, I'm following the guru of peritoneal dialysis access here, and here I am, this nephrologist, going to talk to you guys all about PD access, and I feel like, who the hell are you to give any sort of advice? And so what I'm going to do is really tell my story of what happened in my program, offer some solutions that we found. They may not be your solutions, but I think it's important. We talked a lot about the challenges in operationalizing what John talked about, but I wanted to sort of talk about how we should be thinking outside the box and looking at each of our own programs and thinking about how we can improve PD access. And so this is just my story. And with that in mind, my disclosure is I do not put in PD catheters. And I mentioned that I'm anxious because, I'm following John Crabtree's talk, but I'm also anxious because I'm very cognizant that I am in the wild, wild west of Western Canada. And you pretty much have a lot of nephrologists out there who are inserting PD catheters. And so, again, who am I to talk to you guys about PD catheter insertion? Because I don't put in PD catheters. And so, again, it's really going to be coming from my experience in my program. So I was fresh out of nephrology fellowship. There I was. Everything seemed possible in the world, and I was going to conquer things. And one of the reasons that I was hired at St. Michael's in Toronto is because there was really a struggling peritoneal dialysis program. And basically, the division head at the time, Kamal, said, Jeff, I want you to grow PD. And although I was smiling for the picture, in my mind I was thinking, gosh, how am I going to tackle this? What am I going to do? And we really faced a big challenge in our program. And I thought that if the PD program didn't grow, it would be my skin and really would be a failure in terms of the reason that I was hired. So, when I look at it, and I think Matt Oliver has done a really great job to articulate what the challenges are in getting patients on peritoneal dialysis. And if you think about it, there are 6 steps that we all need to think about in our patients to achieve peritoneal dialysis successfully. We have to identify a patient with end-stage renal disease. We have to assess for PD eligibility. We have to offer PD. Patients have to choose PD. We have to attempt a PD catheter. That PD catheter has to be successful and work well, and then start PD therapy. Any deviation from this sequence of events, any bottlenecks in your program, and you may be having challenges in terms of getting appropriate patients on home dialysis. And so in our program, if you think about it, and we went through it, I think one of the main barriers was assessing for PD eligibility between step 2 and step 3, and also attempting a PD catheter that was successful and starting a patient on PD therapy. So I want to talk a little bit about these bottlenecks, but as you go through your program, think about what you think some of the challenges are in your program. And so we have a nurse navigator named Mina, and she's our PD access coordinator. So people like John, surgeons, they have very busy practices, and many of them aren't well versed in who needs to start dialysis and when they need to start dialysis. And literally our surgeons were seeing patients first come, first serve basis. And of course that doesn't really fit our needs, which is we want the patients who need to start dialysis the soonest to have the access the quickest. And so the Ontario Renal Network functions very much like the BC Provincial Renal Agency. And we were lucky enough to have funded an independent dialysis and body access coordinator. And the idea here was that it would facilitate patient education and assessment for home dialysis and also appropriate body access. And we participated in a province-wide quality improvement collaborative to improve the uptake of independent dialysis. And one of the things that I think we had to do from the start, which we were doing in our program, we weren't doing in our program until I joined, was measuring our PD access rates. You come to these meetings and it's almost like a bit of a pissing competition, because someone will come up and say, well, we have our PD catheter function rates about 98%, we only have 2% dysfunction, and someone else will say, well, we have 1% dysfunction, and you really, you don't know your data till you look at it and you interrogate it and you provide quality improvement. And all of us should be looking at our peritonitis rates in our program, but how many of us do CQI on peritoneal access? How many of us sit once a year and say, these are our access outcomes, and sit with the people who are inserting the PD accesses? And that's extremely important for us to do, because as we're appreciating, and PD access and a successful PD access is every bit as much as important to establishing a patient who's doing well on PD as reducing peritoneal dialysis infections. Yet all the literature is so much built towards CQI and peritonitis with very little around PD access, and I think that's a big limitation. So we measured PD access function locally. We started our own database. We started to collect some of our PD access outcomes. And then we showed our operators the data. And again, nothing speaks more volumes than showing your operators what their success rate was. I just want to put a plug in for 2 studies that are really extending this sort of local homegrown data collection to more rigorous studies. The first is a study in the UK that's trying to do this as part of an ancillary study to the PDOP study, which will look at peritoneal dialysis catheter function across the entire country in the UK, and we'll have some data on what sort of targets and benchmarks we should be looking at least in the UK. And another study is the ISPD North American Chapter Pd Catheter Registry. And I just want to put a plug in. This is some work being done by Matt Oliver, Rob Quinn, Eric Wallace, and Rachel Fassell in the United States, which is really to help create better definitions for catheter-related complications, benchmark our results to programs in North America, and try and identify key practices that improve patient results and participate in peer-reviewed research. So if anybody anybody is interested in joining this catheter registry, I'm happy to send some preliminary information. But that being said, this was our St. Michael's data when I first started. We had 61 IR insertions with a 21% flow dysfunction rate. We had open surgical procedures that were still being done that had 26%, and we had 6 laparoscopic procedures that had a 33% reduction, so 33% flow dysfunction rather. And so there's 2 issues here. One, as John said, we were not doing advanced laparoscopy catheter insertion. In fact, I don't think that the laparoscopic procedures were even advanced in general, and most of our catheter insertion when I first started was being done via an open surgical procedure. And you had these 3 senior surgeons sitting at the conference room table, and me, maybe 3 months in or 4 months into my nephrology staff position, telling them that what their flow dysfunction rates. And I expected them to say, this is wrong, or this isn't enough data, you got to go back a few more years, and blah, blah, blah. And they actually said to me, we're not interested in putting in Pd catheters. This isn't something that's in our purview. They were urologists. They said, we have cancer surgeries that are more important. We have transplants that we have to address. This is sort of a sidebar for us, and we're really not very interested and motivated. And as John said, the remuneration was poor. So I left that meeting extremely disappointed. I left extremely upset and frustrated and not knowing where to take it from there. So I showed the operators unacceptable results. I showed them pictures actually as well. I showed them exit sites that were inappropriately, sorry, I'm using the laser pointer over here. It's a little bit hard for me to do it over there. I showed them exit sites that were placed at the belt line, and this was one patient who never made it to PD because of a poorly placed exit site. Anchoring sutures that were being put at the exit site, which of course is an absolute no-no, and this person developed an infection and again, never made it to peritoneal dialysis. And then I realized that they just weren't interested. And, I had to take it up a notch. So then I showed these results and I spoke to my hospital administration team. And I think, to Maura's point, I think it's really important to empower yourself with data. Administrators are numbers and dollars and data-driven individuals. And so I showed my hospital administration team the data. And of course, I expected her to sort of sit on her feet up as they do in their offices and say, that's your problem, Jeff. But you know what? She was extremely receptive, and she said, that surgical response is just not acceptable. And as it turned out, one of the surgeons was approaching retirement, and what she said is that she said the next surgeon that we were going to hire at St. Mike's had to have advanced laparoscopic PD catheter access training. And there was going to be no questions, ifs, ands, or buts about it. They were going to have a dedicated part of their practice devoted to PD access. And I was really happy with that. And so we developed a PD access team, and luckily just finishing his fellowship in California was Jason Lee, who is our surgeon who puts in peritoneal dialysis catheters, and as John alluded to, attended a peritoneal dialysis university course for surgeons and learned about advanced laparoscopic placement, which was a really nice fit to his laparoscopic fellowship. There was me, who was the nephrologist as part of the team, and this was our PD access coordinator. And so the person that does all of the modality education in our program also coordinates the list so that Jason doesn't have to, triage PD catheter access, who's going first. We actually sit as a team, Mina and myself, look at all the referrals for PD access. They all get funneled through Mina so that Jason really sees the catheter insertion requests in order of importance and in order of emergent need for dialysis. And every month we shuffle that list a little bit so that the most needy patients for a catheter are the first ones served, and those who can wait another month or two. And I think it's created a lot of efficiencies in our system. And we realized that without supporting Jason with administrative roles like Mina plays, it really would be a dog's breakfast for him and his admin to try and sort out which patients to see first. So we had a PD access coordinator, which I talked about. We also didn't want to abandon interventional radiology, and I'll talk about why. We had them seek additional training in PD catheter insertion. We meet annually with them to review and audit our data. And of course, the advantage with IR is that it's easy and ready accessibility for urgent PD catheter insertion. There's just no way that an urgent start program would be sustainable in my program with surgical insertion, and I'll talk about our setup. And of course, support for PD catheter dysfunction with providing IR manipulations. And again, to Maura's point, I'll talk about manipulations in the data there. With regards to the surgeon, as I mentioned, received advanced training. And one of the other things that was extremely helpful was to have mentorship from Dr. Todd Penner, who also is sort of the local Canadian expert in advanced laparoscopic PD catheter placement, who spent a day with our surgeon in the OR doing cases together. So the PD Catheter University, coupled with the mentorship, was extremely important. And then for my role, I think, is really a resource for PD access coordination for challenging cases and to really to provide the medical insight into who needs a PD catheter the soonest. We exteriorize embedded PD catheters when placed. So my surgeon will talk about our embedded program. My surgeon said, I'm only going to embed catheters if you exteriorize them because I have a lot of things to do. I'm really busy. So that was the deal we made. He was going to provide embedded PD catheter placement on the proviso that I assumed ownership over the exteriorization. And so far that's worked well. And then, of course, we worked with the team to determine some of the post-PD access insertion prescription considerations and how each patient should be looked at individually as to when and how to prescribe the PD immediately following catheter placement. And I'll show you some examples there. So we have our surgeon in place, we have a PD access coordinator, we have an administration team that is in support of the data around the poor catheter outcomes at our program. Then the next challenge, which John alluded to, was to secure operating room time in my program. And again, as a tertiary care trauma center with transplants, that lineup that John showed is also playing a role at my center. And this was a little bit more challenging. Luckily, there was a lot of unused and funded OR time for living donor kidney transplants. And fortunately or unfortunately, probably more unfortunately than fortunately, living donor transplant rates were not as expected and as projected in our program. So we had ORs that were paid for by the program for transplants that weren't happening. And so we borrowed from that 1 day a month to have a full PD OR day. And I thought, wow, this is going to be the end of our problems. We have 1 OR day a month, we have a surgeon who's now motivated, we have a team going, and this is really going to be a great situation here. But then we realized, actually, every month, the number of patients who need a PD catheter changes. So from 1 month, it could be 5 patients. Another month, it could be 2 patients. And you guys know that it goes in ebbs and flows, right? There's not a consistent number per month of patients who need a PD catheter inserted. And so I was, there were months where we were doing 2 or 3, and Jason had blocked off his morning. And I thought to myself, oh gosh, I said, what are we going to do? Because we're not filling the operating room time that we have. We've asked for it. We don't want to have it taken away. So then we had to think of a strategy to actually have consistent and ongoing PD catheter OR time and days and cases across months from month to month. So, that's the problem. Who needs a catheter is variable, and we realized the same number of cases weren't happening every month. And I think that's really where our embedded PD catheter program started to really try and fill in the gaps here. And so we developed this algorithm, and again, this is open for discussion. This is just sort of what we do. If someone needs a PD access, if it's urgent and they have an uncomplicated abdomen, and again, uncomplicated abdomen, there's very limited physical exam type information you can use, because as John has showed, a lot of the stuff you don't find out until you're actually with your laparoscopic camera in the patient's belly. But having said that, if they have a seemingly uncomplicated abdomen and they need it urgently, we'll do interventional radiology. The other time that I think interventional radiology is very helpful is if there's a concern regarding a general anesthetic. In that case, for our 90-plus-year-old patients or patients with comorbidities, I think many of them choose an interventional radiology placed catheter. And interventional radiology and nephrology, I think we could use interchangeably for the purposes of talking about a percutaneous method of catheter insertion approach. And so, for patients where there's a concern regarding a general anesthesia, interventional radiology. But, the truth is that our default is laparoscopic, advanced laparoscopic catheter insertion in our program, barring no issues with the urgency of the catheter and the concern regarding the general anesthesia. And then once we decide that we're going down a laparoscopic catheter approach, if the catheter needs to be used within a month, we'll do a non-embedded approach. If we have more than a month to go, we'll tend to put it in an embedded PD catheter. So that's the approach. Interesting in the discussion part of the talk to hear your feedback on your approach. Now, we've had a few cases where someone had a colectomy or a colostomy, and there was a real concern about an interventional radiology catheter, and also a concern about general anesthesia. And although John didn't mention it, Dr. Penner at Toronto Western uses a different type of gas than carbon dioxide. It's nitrous oxide, where you could insufflate the abdomen under local without needing a general anesthesia. And for a few patients who I really felt strongly needed a surgical catheter insertion and who also were a bit squeamish about general anesthesia, I referred them out to Toronto Western Hospital, at least to have an attempt under local, because a lot of the times you need to convert these local procedures to a general if there's a lot of stuff to do. It can get a little bit tricky keeping them under local. Having said that, just to have the possibility of doing it under local. And interestingly, the two cases I sent out were both colectomies due to cancer for a colonic resection, and they had adhesion-free abdomens and had their laparoscopic catheters placed under a local anesthesia. And it just goes to show you, we really do a very poor job of predicting who's going to need the advanced procedures and who is going to have smooth sailing. And I think that's a real advantage of being able to look in and see what's going on. And as we talked about, interventional radiology is gaining momentum in the PD space, and this is their mug, inventing procedures for other specialties since 1973. And so it was a real advantage to engage our interventional radiologists to put catheters in. And this is just some of our data, and I just, over time, what you can see is that the OR catheters increased as a proportion relative to the IR catheters. And again, this is just our most recent data. And again, if you see 66 PD catheters inserted for 65 patients, we had a flow dysfunction rate of around 21%. Again, this was for our IR catheters, and that's just really the one that I wanted to point out. This is all the pathways of what happened to all of them, and we had 4 complications. Again, one was a bowel injury, which is concerning, and a bladder injury, an infection and a leak. And these two, I think, were probably potentially avoidable with advanced laparoscopic placement, where it would have minimized the risk of bowel and bladder injury. So again, these complications do happen and are concerning. One of the things that Mauro talked about in your question was about using interventional radiology as a source for manipulation. In other words, in my crude understanding, putting a wire through the catheter and trying to get the flow dysfunction restored after there's been a problem with either both inflow or outflow obstruction. And one of the things, if it's a practice that you're going to continue to do at your center, I feel very strongly that patients should get pre-manipulation antibiotics. You're sticking something forward into the PD catheter. There's fairly good randomized control trial evidence to give prophylactic antibiotics at the time of catheter insertion. I would support extending that without evidence to patients who are undergoing any sort of fluoroscopic manipulation. So again, that's something that we do in our program. One of the things that we reported on, interestingly, is that you see this catheter here, you can see the outline of this catheter, and the catheter is actually right up here. And what ended up happening was a fibrin sheath of the PD catheter. So although we think about fibrin sheaths in hemodialysis, we describe this phenomenon in peritoneal dialysis as well. And there's been a couple of case reports since our description about the same phenomenon. So I thought that this was an interesting type of flow dysfunction that we saw. And this was occurring during one of our interventional radiology manipulation procedures. We had 4 cases that were IR insertion where the catheter was flipped. And I guess John could comment on this a little bit more in the discussion section, but in my experience, all of these 3 were unsuccessful with manipulation, and 3 out of the 4, one decided not to continue on PD, but among the 3 out of the 4 who went for manipulation, they had to have a surgical revision to fix this problem. So for a flipped catheter, I've been unimpressed with fluoroscopic manipulation as a means to improve and restore function. So the catheters were unsuccessful. Similarly, we had in the beginning, early days, 3 OR cases where there was a flipped catheter. And again, all of these needed surgical revision as well. And again, the point I'm trying to make is that if a catheter is flipped, there's very limited utility, I think, for fluoroscopic manipulation. And we were learning that the hard way. And just again, to Maura's point, we have done 31 manipulation procedures. 13 of them were for IR placed catheters, 18 for OR. And you can see here that they have very high rates of success, very poor rates of success. 72% were unsuccessful with an OR catheter with manipulation, 85% with an IR. And among these, 9 and 11 had to undergo surgical revision. And really, like I said, we had 0% success among flipped catheters and 22%. You could argue that this is sort of a Hail Mary thing to do before you have to send a patient to the OR, that you're going to send them to IR, you're going to try one last ditch, non-invasive attempt before you send them for surgical revision. But the truth of the matter is it can be quite painful for patients to undergo manipulation, and I think we probably set false expectations for the manipulation. So I must say that reviewing my center's data has made me a little bit more pessimistic about the role of fluoroscopic manipulation in restoring catheter patency. What was really interesting here is that we wanted to go and look and see among those catheters that had flow dysfunction, that had to undergo surgical revision, what was it that the surgeon found, both for IR placed catheters and OR placed catheters, that was the cause of the flow dysfunction. And you can see here that omental wraps really topped the list for IR placed catheters. 89% of IR placed catheters failed to function because of an omental wrap that obviously couldn't be addressed with an IR placement. 36% in the OR placed catheters. A very tricky and stubborn fibrin clot was responsible for 36% of the OR catheters, and that's something that's very hard to address. I mean, it's something that probably developed post-OR placement. And again, as strong as my PD nurses' bicep muscles are, I guess they couldn't force the fibrin out of these catheters, and only one case in the IR group. And then some bowel wrap or fat around the catheter. And since I've looked at this data, we had one fallopian tube that was wrapped around the catheter. Again, something that was found after, and that was a surgically placed catheter that subsequently had a fallopian tube wrap. And what were the procedures that had to be done? Oops. The procedures that had to be done to fix these were an omentopexy, obviously in 4 of the cases and 8 of the IR cases, and also there were further adhesions to lice. So the one thing that's really interesting is that if chances are if a patient is going for a revision of a percutaneously placed catheter, this data, and it would be interesting to see other data, would suggest that an omental wrap is probably playing a large role in flow dysfunction following a percutaneous catheter placement that requires revision. The other thing that I want to make is that our surgeon was routinely assessing and evaluating patients for omentopexies, and I wonder if we should be thinking about more liberal use of omentopexy in more patients up front at the time of laparoscopic catheter insertion. And again, this is a question for you because if the surgeon went in the first place and didn't do an omentopexy and yet there was an omental wrap, I just would ask John, what's the downside to doing it a little bit more liberally in more patients to avoid this situation? And this is information we're going to feed back to our surgeon to try and improve upon. And again, one take home is maybe omentopexy should be used more liberally in surgically placed catheters. One thing that is no doubt playing a role in all of our programs is variation by operator. And though I showed this in an unblinded fashion, in a blinded fashion rather, I was unblinded to it. Looking at our IR placed catheters, we only have one surgeon who does the surgical catheters, but looking at the radiology placed catheters, you can see we have 3 interventionalists, and I actually could predict this before the data was looked at, but you can see that if you look at the complication rate, A by far has the lowest complication rate, and A has been doing it the longest and has the most motivation and experience. B and C have had similar rates of complications. So again, I think it's important, and I think it's important for your operators to see that there's variation between colleagues because that will really feed into quality improvement strategies. One thing that I went to look at in the literature and is supported by the Ottawa experience is they also looked at the success of their manipulation experience. And although this doesn't project very well, when they looked at what predicted failure of a manipulation to restore catheter patency, one of the biggest predictors was that the catheter was flipped, in terms of the catheter position inherently being flipped on X-ray before the manipulation, and if the catheter never worked to start. That kind of makes sense. If the catheter never worked, a manipulation may be less successful than if the catheter worked and then stopped working. And again, their success rate was about 20 to 25% in this Ottawa study. So I want to talk in this part of the talk about embedded PD catheters. Really, like I said, it was filling a need for us to have consistent cases of PD access going month to month. And this is an embedded catheter, and this is just me showing where I would be exteriorizing the catheter in this particular patient. And one of the things that I had to do is learn how to exteriorize PD catheters, and like many things, I learned how to do this from one of our nurses. A nurse practitioner at Toronto General Hospital had been exteriorizing PD catheters, and there's a very special instrument you need called a Graham hook to do this. There's a video on UKidney that you all are welcome to look at. This Graham hook now has been a little bit difficult for programs to find, and I recently had to courier one to PEI for an exteriorization to be done there, and they couriered it back. And when I sent it, I said, you guys better return it. You're on the hook. Get it? Because it was a Graham hook. Anyways, so if anybody wants more information, I'm always happy to provide it. And this goes through the whole protocol of how to do it, what you need from start to finish. And with this in mind and these changes, our PD prevalence did go up substantially at St. Michael's Hospital. And so I think that, improving the trajectory of access at our program was a huge game changer at St. Mike's. And again, if you look at our pre-dialysis clinics, more patients were starting on PD after these changes than were starting on PD before. And again, this is the first part of that period, 2008 to 12, and 2012 to 16. The other thing that I want to point out is your surgeon is somebody that is a key, or your interventionalist, I should say, is a key member of your PD team. They need to be part of the discussion. They need to be part of the quality improvement initiatives. And so I think what's really important is good communication. So every month when we have our PD catheter insertions, I get a very detailed report of what went on in the OR. And I think it's very important for the nurses out there to read those reports, to discuss with the surgeons what happened, because you might be primed to treat that patient differently, knowing what the operative findings were. And again, I'll give you some examples. So this patient had major pelvic adhesions and omentum, lysis of adhesions and omentopexy, was able to salvage the existing catheter, so this was a revision. Given adhesions, he left some fluid in the peritoneum, and again, to prevent those adhesions from reaccumulating, there's a suggestion that more frequent flushing might be indicated. So this is the surgeon feeding back to us in terms of a role for nursing care for more frequent flushes in this case. This was an embedded PD catheter that had minor adhesions and required an omentopexy. I like this terminology. His pelvis was very friendly, but while the fluid was irrigated in very easily, it was somewhat slow to drain. We looked back, and for some reason, fluid preferentially collected in his paracolic gutters. He's on the big side and had a lot of intra-abdominal fat. We'd still another liter of normal saline, and it drained out, so may have some residuals. So for the nurses out there, someone who might have a large residual volume, who you're starting on the cycler, what might you need to do? Anybody? What will help in somebody who's not completely draining everything in their abdomen? What type of a cycler PD prescription? Yeah?
Title.
Exactly. So that's exactly what we did, and knowing that up front, anticipated the potential for alarm. So this person started on tidal dialysis when they were ready to go. This person had a major omental wrap. Catheter was extricated. Again, a revision. An omentopexy was performed and irrigated well. This one had an embedded PD catheter, had an umbilical hernia that was repaired. Again, speaking to John about the really important role of adjunct procedures. Now, he says it for me, for the exteriorizing team, unlike most of our buried catheters, which have a small white plug, his catheter is tied off with silk. The tunneling device poked through the tubing, so I had to cut it off. So again, this tells me that I may have a little bit more challenges when I exteriorize it, because I may have a more resilient catheter. But again, this is just to show you that communication with your surgeon is really important. The other thing that's important to know is that, if you look at patients who start dialysis in hospital with a catheter, about 56% of these patients have been referred early. So we can't blame it on the crash starts or the poor family doctors who aren't monitoring these patients. These are patients that we've all been seeing in our CKD clinics for many years who still start dialysis in hospital with a catheter. And when they went in this study to look at why patients were starting suboptimally, patient-related delays played a major role. Patients often have a hard time making modality decisions. And unfortunately, the default becomes an urgent start in hospital. And again, we can talk a lot about what are the strategies to improve that, but I think the reality is that even though we're following these patients, there's always going to be a segment of patients who start dialysis in this manner. Of course, there's the acute on chronic kidney disease. It's very hard to predict. So Mr. Smith gets pneumonia, gets admitted to hospital, creatinine jumps. Those are always going to be part and parcel of the type of patients we see. Late decisions by the team, luckily, were only 9%, and surgical delays were 16%. So the point I want to impress here is that suboptimal starting with a catheter in hospital, isn't just a crasher, doesn't know they have end-stage kidney disease phenomenon. It's a phenomenon that's part and parcel of still the patients who have very good pre-dialysis care. The other thing that's really interesting is when you look at the variation by nephrologist, they didn't really see a center difference in patients who started with a catheter as an inpatient, but they saw is a nephrology difference. So nephrologist A has a much higher suboptimal start rate compared to nephrologist N. And it's really interesting because it suggests that maybe there's things we can learn from our colleagues that might improve our approach to dialysis initiation with our patients. So, the current state is that when patients start urgently, they get a hemodialysis catheter and start on facility hemodialysis. And I think one of the strategies is for early referral patients to think about an embedded PD catheter, and then you can start them on urgent PD at any time point. And again, I'm not talking about urgent start PD, which is a whole other way to address this axis. I just want to focus on embedded PD catheters as one strategy. So at Western Canada PD Days a few years ago, I was very fortunate to meet Dr. Moncrief, and the embedded catheters is the Moncrief-Popovich technique. And the original idea was that if you put catheters and let them heal under the skin, you would reduce bacteria formation on the catheters by letting them heal in a sterile environment and reduce infection risk. And like many things, what was invented or thought of for one purpose ultimately gets used and is leveraged for other indications. And I think that there's no data that embedded catheters have any difference in the risk of catheter and infections and peritonitis, but they certainly are a very efficient way to address access challenges in your program. And the analogy is kind of like Viagra. Viagra started off as an antihypertensive, but of course we know that it has another indication that's extremely beneficial. So what are the advantages of embedded PD catheters? Well, ideally, it could be left in for an indefinite period of time. I find myself calling them buried catheters, but I'm really careful now around patients because patients don't like to hear the word buried around them, and you can understand why. So I try to use the terminology embedded. So embedded catheters can be left for an indefinite period of time. The incision or stab in the peritoneal cavity can heal for a longer period, and therefore we don't have to worry about lowering volumes. Patients can start with full volume PD initially. They have an access that's ready to go like a fistula, and they can have elective insertion when a patient is stable. So yesterday I heard about some real challenges in rural regions with Aboriginals with flight delays and whatnot. And again, imagine if you're getting it down to the 11th hour where someone needs to start dialysis in 2 weeks and you're trying to get a catheter. As a strategy to people who live in more remote communities, this might really help fill that need of having an embedded catheter because you can plan it a long time in advance when patients are well. And so they have an access that's ready to go like a fistula. And again, elective insertion when the patient is stable and much more flexibility. And again, because they have prolonged healing, you don't have to worry as much about leaks. So these are all the advantages. The other thing that we noted is that it stages the patient's readiness for dialysis. Not having to see that access, we don't appreciate it, but when someone has a PD catheter insertion, their body's never going to be the same. They have something foreign in them that is reminding them that they're a sick person that needs life-sustaining therapy. That's very traumatic, and we usually couple it with the time of starting dialysis, right? What dialysis modality are you going to have? Now we're going to stick in a PD catheter, and it's a lot for a patient to digest digest who's just coming to terms with end-stage kidney disease. And so I think that this also stages dialysis initiation for patients. And it's amazing how many patients had, and this is really interesting, how many patients had agreed only to have an embedded catheter, but really didn't want to have the catheter primarily exteriorized. And I find that fascinating, and be interesting to have a discussion about that. I think it's overwhelming to couple dialysis access with dialysis initiation. And when I first started in our pre-dialysis clinics, we would say, okay, if you want hemo, we have to make a fistula now. It's going to take months to mature, and then, in a few months' time, we'll be able to start you on dialysis. But we have to make this fistula now. Or you could wait, and about 2 to 3 weeks before you need to start dialysis, we'll think about a Pd catheter. Well, what would you pick if someone said, cosmetically disfiguring procedure now versus a potential procedure down the road? And I don't really, in the back of my mind, believe this doctor, that I have end-stage kidney disease. What are you going to pick? So a lot of patients were picking PD as a cop-out to not having to commit to an access. And what I find that embedded PD catheters does is it says to the patient, let's make the access decision now, and the modality decision coupled with the access. So at this point, you have to let us know, are you thinking down a hemodialysis pathway, be it home or in center, and should we go down a fistula or graft creation road, or are you thinking about PD? And then I think now it's appropriate to get an embedded PD catheter placed. And it really levels the playing field between PD and hemodialysis. What are the disadvantages of embedded PD catheters? Well, there is no doubt you need 2 procedures, but one is a very minor one, I would say. And of course, we don't want to be doing this and have a high rate of futility or non-use, either because patients die in our CKD clinics with embedded catheters. I think it'd be a travesty if someone changed their mind and switched to a modality with a hemodialysis with an embedded catheter, and of course for patients who are transplanted. And we obviously don't want to have them have had an embedded catheter if we knew that they were going for a transplant. But how many of you had patients saying, I don't need dialysis, I'm getting a transplant? Show of hands. And how many of you have had patients who have not ultimately gotten that transplant for one glitch or another? So, this is the thing. So I think more often than not, you end up using the embedded catheter than not. And I say, you know what, I want you to have this transplant. Let's go full guns ahead to get this going. But as a backup, let's have this embedded PD catheter. And it's amazing. I don't think I've ever had a case so far where we haven't actually used the catheter. So let's talk about some data. The Ottawa experience is they've pioneered, I think, in Canada, some of the literature around embedded catheters. They had 435 catheters that were embedded. 50 stayed embedded at the time of the study. 349 were exteriorized, and 38 weren't exteriorized. So the sort of futility rate was about 9%. And interestingly, they looked at, the question I get asked is, if it stays in longer, will it work less? And that's, I think, a controversial question, but they looked at different tertiles, catheters that were in for 11 to 47 days, 48 to 133 days, and 134 to 2,041 days. And whether it's a statistical fluke or not, the catheter that had the lowest failure rate at 1.7% was the one that was in between 48 to 133 days. So, I don't know if this is a statistical fluke or not, but interestingly, the catheters that were in before being exteriorized for the shortest time had a similar dysfunction rate to tertile 3. And, there's 2 ways to interpret that. Early exteriorized versus late have no real difference, or middle ground catheters seem to have the best outcomes. And again, this is just showing it to you in a Kaplan-Meier curve, the same type of results. In Portugal, again, 467 patients had PD catheters inserted. Again, the comparator groups, we would argue, might not be so appropriate. 200 were laparotomy, 76 were a blind Seldinger technique, and 180 were open surgical and embedding. And again, as you can see here, the break-in period for the Seldinger was about 20 days on average, 26 days for the laparotomy, and 55 days for the embedded catheters. And again, if you look at exit site infections, interestingly, with the embedded catheters, they seem to have a lower risk of exit site infections. Whether that's fluke or not, I'm not sure. Obviously, they had a lower risk of leak, which makes sense. They had a longer break-in time. No difference in peritonitis, and no difference in the risk of obstruction. Interestingly, though, if you look at catheters that were embedded for 6 months or longer in their study, there was a 16% dysfunction rate, and catheters that were in for less than 6 months, a 4.7% dysfunction rate. And that was non-statistically significant, but a signal that maybe the longer-placed catheters do suffer from a greater risk of dysfunction. And again, this is just their data showing catheter survival, which was no different between the three groups. In Colorado, in Isaac Teitelbaum's unit in Denver, they reviewed their embedded PD catheter data, 122 catheters. They had a 90% function rate, and among the 10% dysfunction, there was a fibrin plug or kink or an omental wrap in the majority of cases, and all of them except one corrected by laparoscopy, and the duration of embedding really didn't affect the function. This is, again, just a summary of studies, and what you see here is the wide variation in initial drainage problems with embedded peritoneal dialysis catheter, and a very wide range from the time of insertion to the time of exteriorization. So again, I think that, what's really confounding the data around embedded catheters is that they're all being inserted in different centers with different methods, which similarly confounds the non-embedded data. So it's very difficult to make heads or tails of this. This is what a fibrin plug looks like. You have to really vigorously aspirate clot. And again, you can see here the little spikes from the little ports along the catheter and a long piece of fibrin. This was sort of me having fun because I exteriorized the catheter with Mina, and this is me. So we kind of do these kind of stupid things. This is a slide I borrowed from John, just showing you that the suture can get very, if you tie the catheter, it becomes very difficult to exteriorize it because it forms a mat of scar tissue. And we've had a lot of success following John's technique of inserting, what's this device called again? Vexel, and actually snapping it off. And this is what the blind end of the catheter looks like when we exteriorize the catheter. And we've had a lot of success with that. So what are some clinical pearls that have helped us Mina a time? Always have a PD catheter repair kit handy at the time of exteriorization, because you never know when something might go wrong. The biggest risk to injuring the catheter is actually the freezing, and the freezing getting in, the puncture actually puncturing a hole in the catheter. And the other thing is, you don't want to exteriorize at the 11th hour. Yes, you can start dialysis right away, but the thing is that you really should try and do it a day or 2 or 3 days before you want to use the catheter, because the same things are going to happen. The patient might have a full belly and might need to do a bowel clean out. And so the other thing is that you want to warn patients that a revision might happen and don't make them feel bad. We all sit there when a catheter is being tested for the first time and they see our anxiety. It's not working, it's not draining, what do I do? Call Dr. Perl. You got to say, we know this is our dysfunction rate. About 10% of the time the catheter might not work. We'll deal with it if the catheter's not working. And I don't put pressure on yourself or on the patient, because I know probably the most frustrating call I get from a nurse is that the catheter's not working, right? It stops you right in your tracks. But again, we got to not let our anxiety feed on the patients. And if it doesn't work, don't let them pick up that anxious energy, because I think that's worse, more so than anything else in this whole process. Other things is if your program does do staph aureus eradication, to me it makes sense to try and do that before the exteriorization, just while the plastic is inside, not outside. Also have an aggressive bowel routine before exteriorization. I've learned this the hard way. People should pee first and have an empty bladder, both for their own comfort for the procedure. And if they're an inpatient and have an embedded catheter, this was an almost near miss in our program. Do not give them blindly subcutaneous injections of heparin or insulin. Be very careful and make sure that the patient has a note or a sign in their room that they have an embedded catheter, so to be careful with intra-abdominal injections, because that was almost a scary situation for prophylactic DVT prophylaxis and for insulin. So this is our embedded data in our program. This is before we started to embed. Again, with our laparoscopic, we had less than 5% mechanical complications early on. And again, this doesn't project very well, but this is our embedded catheter data, and we had no leaks reported. And, for our embedded catheter data, again, you can see that we had 9 that needed a revision of 71, so a little bit more than 15%. And similarly for our non-embedded catheters, 10 out of 10 out of 81 that needed a revision. And this is just summarizing it here. Again, these are our embedded catheters that had primary non-function, about 15%, 20% non-embedded, so no difference in our program, and pretty much the majority of them, except for a couple of cases, worked after the catheter was surgically revised. Is there a benchmark? Is this good? Is this bad? I don't know. We need more data. We need more centers so we can all establish benchmarks. The only thing I could find is Dr. Crabtree has recently published on this in PDI, and the overall flow dysfunction rate was 14.3%, and 98% functioned after having a surgical revision procedure. So I thought, okay, if, John, who's the king and guru of PD catheters, has 14%, I'm going to be really happy with my surgeon's results. And so we really use John as the gold standard for, our quality improvement initiatives here. The other thing to think about is, what happens when a PD catheter is not working? Where does the patient go? If they need to start hemo, they go to in-center hemo. Then what happens? They sit next to Mrs. Schwartz. Mrs. Schwartz tells the patient, you're going to do PD? I had the worst peritonitis and the worst experience ever of my life. Don't let them talk you into PD. So they're going to get lovely modality education in the in-center hemo unit waiting for a revision. Then Mina's going to come by and she's going to say, okay, well, we've booked your revision for next month. And the patient's going to be like, well, you know what? I have my blankie here. I have, this lady next to me who's telling me, PD may not be such a great option for me. The nurses also in in-center hemo, some of them have biases against PD because they only see the failures, they don't see the successes. So we don't really create an environment in the in-center hemodialysis unit that's really pro-PD. And so what we do with these patients is, this was somebody who had flow dysfunction, who needed to go on interim hemo. We dialyze them in our home dialysis unit in the transitional care room. So this is sort of a rhyme, but I say transitional care when the access is in need of repair. Don't let them go to the in-center hemodialysis unit. Do not. Maintain them in home dialysis. Let them see home dialysis patients that are doing well. Let them appreciate that this is just an early hitch that we're going to overcome in a very supportive environment. One of the things that I think tells a story is, this is when the nephrologists referred patients for embedded PD catheters. These are the EGFRs. And what you can see here is that we really have a wide variation of EGFRs at the time that catheters are being inserted. And again, each patient should be looked at differently, but I wonder if these catheters were prematurely inserted in a lot of patients. And can we hone down on this a little bit more and have a more rational approach to access insertion? And again, if you look at the days to exteriorization, they're quite variable across the different types of catheter insertion. And again, what this says to me is, we as nephrologists clinically do a really crappy job of predicting who's going to need dialysis when. Because nobody put an embedded catheter in a priori saying they're going to start dialysis in 2 years. We all thought they were going to start within 4 to 6 months. And this person didn't probably put it in thinking that they were going to start within a month. So we really, I think, do a very poor job of predicting who's going to need dialysis imminently and who's not. More so when the margin is 4 months, not like in a month. And just to show you, in our program, really duration of embedding didn't affect dysfunction. These are the cases of flow dysfunction scattered across the different time from insertion to exteriorization. One thing that we've started to use in our program is the kidney function risk estimating equation developed from Nav Tangri at the University of Manitoba. And again, what does show a very nice correlation, and what you see here on the x-axis is the KFRE at the time that the catheter is inserted, and the days from catheter insertion to exteriorization. And what you can see is that there seems to be a linear relationship between the KFRE and the need and the duration of embedded time. So in other words, the patients with the highest KFRE have the lowest exteriorization time. And we're going to collect this data a little bit longer to try and develop KFRE cut points at which time to insert the catheter and help rationalize it. And this is similarly the relationship between GFR and the days to exteriorization. Similarly shows a relationship, but a little bit stronger with KFRE. Another thing that's been looked at, and this was from John's paper, looking at serum albumin. Interestingly, serum albumin seemed to correlate between duration of catheter embedding time from insertion to exteriorization. So perhaps we can use albumin, KFRE, in addition to our clinical judgment to help make this decision a little bit more rational. So just to summarize, I think that what I want to impress upon you today is that early referred patients are also at risk for urgent dialysis starts, and we need an approach for them. A team approach is important for successful PD access. It's not just the surgeon. You all have a role to play in successful PD access in your program. The other thing is you don't know your program has a problem until you measure it. We're still challenged with our IR catheters. Based on the most recent interrogation of our data, one of our interventionalists will be attending Pd Catheter University for interventionalists to better hone-tune his skills, and to his credit, he's responding to the data we've presented. I think we still need a benchmark for functional PD catheters. We all know that ISPD guidelines say your peritonitis rate should be no higher than X in 50 patient months. Well, what should our flow dysfunction rate be? 0, 2%? So the next time somebody comes up to me at a meeting and says, well, we have 2% catheter dysfunction rate, I can say that's really amazing. You're in the top 1% of all catheter insertion programs in the country. Because we don't have the data. And I think what we need is a so-called POET, which was a Baxter-run database of peritonitis outcomes. We need a POET for PD access, where we're all collecting and putting in the information in the same way. And maybe the North American PD study might do just that. I think transitional care is really important to minimize attrition from PD after PD catheter complications. And again, once the patients go to the abyss of in-center hemo, they may be lost forever. They may have modality change inertia. I think they need to stay home focused and with home dialysis like-minded individuals. And that's really the philosophy in our program. And I think one of the strategies for the early referred patients is embedded PD catheters. And I think it may attenuate the risk of suboptimal starts. What's the optimal duration of embedding to maximize success? That's still an unanswered question. The KFRE, I think, is really exciting and I think would be a good predictor for exteriorization time to look at in the future. The literature is very muddy by the method of access insertion and the type of catheter and the center. And I think that there's no evidence that it has different function rates compared to other techniques. Really not, I don't think the benefit is for infection. There's no real difference in the risk of infection. Yes, there will be a higher rate of non-use, but what do you think is more worse off? A patient who goes to hemo with a catheter versus the patient who ultimately has a PD catheter that may be a futile placement, and we can discuss that. One of the things that, as I mentioned, the patient-reported experience, the patient journey to dialysis is difficult. And maybe embedded catheters ease that transition. Maybe they make it worse. I think that's something that we need to study. How do patients feel about an embedded PD catheter insertion approach? Do they find it more cumbersome? Do they find it as more of a stepwise transition? And that's something I think would be important to find out. And again, I think sometimes our emotional readiness for dialysis and clinical readiness are very different. And I think working on the catheter insertion earlier on gives us a little bit more opportunity to avoid a suboptimal start. So I don't think that growth in our program would be possible without working together as a team. This is our home dialysis team, and we celebrated 2 years ago now, our hitting 100 mark for patients on home dialysis in the hospital, had a whole event for us, which was very nice. And I couldn't show a slide without my two twins. And again, I hope to be back here in about a year's time for ISPD. Thank you.
Thanks, Jeff, for your excellent presentation. I think John has something to comment on your talk.
Oh, gosh.
Okay. And so, Jeff, I think you're correct. I think you have to be more liberal with the omental pexies to prevent the omental entrapment. Basically, if you are more liberal with that, you should really not have any omental wraps.
Yeah.
The other thing I was curious about, and I'll just ask this question, it's and also have been interested in Tangri's work with the KFRE, and of course I think one of the strong parts of that analysis is that it was the urine albumin to creatinine ratios.
Yes.
And we also found a relationship there, but it wasn't that strong.
Right.
Okay. And of course, we saw that the albumin was a stronger indicator. So the KFRE was, even though it's not really quite very precise on time, though, is it?
Well, the thing is that I think the KFRE we use now in Ontario to risk stratify patients for even admission to a pre-dialysis clinic. They need to meet certain KFRE criteria to get into the clinic, which I think improves the efficiency of pre-dialysis care. We don't want people in the clinics who aren't progressors. The equation was developed at a large population level. The equation had different levels of GFR. I still think at our population in stage 4 and 5, we need to further validate it in more advanced chronic kidney disease, and I think that work should be done, and I think it'll be very interesting work. But, this is just a single center. This is just how we dealt with our quality improvement data. For any of this to have any credence and applicability, I really am a big believer in multi-center studies where we try and amass all of our patients. So I'd like to see all of these studies and all of these analyses replicated in a much larger cohort. And this is where we all, as a PD community, come together to try and look at these questions. Question, and I know that there was a question over here. I haven't forgotten. Sorry. Okay, we'll go over here. Sorry.
Just a quick question on complications and if you've had your experiences with vaginal prolapses and your management of them, and how have you approached?
So vaginal prolapses, we've had a few cases where they have developed after PD initiation because of the intraperitoneal volume of the PD fluid. They probably were well managed before or clinically not as apparent until someone started PD. We've tried engaging our gynecologic colleagues with non-invasive strategies first, but ultimately sometimes people do require surgery. And again, in our experience, we've tended to have the surgery performed with our gynecologic surgeons, and I'll get John's feedback, but we've tended to hold peritoneal dialysis in the post-surgically repair period and then reinitiate it after several weeks. I don't know if that's something that is in your experience as well.
Same experience.
Yeah. Anyways, I've been told that we can't ask any more questions, so I think it's at a break now?
Yes.
Okay.
Thank you, Jeff.
Thank you.
We're taking a break now.
Yeah, thanks everybody. We're a little bit behind, so maybe if everybody could just run down, grab a coffee, use the washroom if you need to, and let's try to get back in about 10 minutes. Thanks.
Hi.